In next 20 minutes, I'm going to talk about one problem which poses a lot of challenges to all of us, and that is premature ovarian insufficiency. So this is a problem which really bothers us and creates a lot of issues when we are talking about women who suffer from this. And I'm also happy to announce that ICOG has granted 8 credit points for our conference this time. So thank you, office bearers of ICOG. As I talk about premature ovarian insufficiency, I'll be talking on these lines: overview, long-term consequences, what the clinicians need to know, and how do we uh, diagnose and treat these women. Premature ovarian insufficiency also is known by different names like premature ovarian failure, premature menopause, hypergonadotrophic ovarian failure, etc., etc. So typically, when there is cessation of menses before the age of 40, we say that probably we are dealing with a woman who has premature ovarian insufficiency. And technically, we expect that the elevated serum FSH levels of more than 25 on 2 separate occasions, at least 1 month apart, it would be associated with amenorrhea. There would be low estradiol levels, but the Indian Menopause Society says, and which all of us would certainly agree, that it is defined as a spontaneous menopause occurring below 2 standard deviations. And when we say 2 standard deviations, in country like ours, we may consider premature ovarian insufficiency below the age of 38. Now, the ESHRE is very much for the FSH estimation and two estimations of more than 25 4 weeks apart. How common is it? World over, it is pretty common. Some countries have a lower incidence where they say that it's about 3.7%, but in our country, it is about 5.5%. And that's a huge number, uh, we all will agree. The European countries report an incidence of about 1%. And when we are talking about premature ovarian insufficiency, of course, the incidence varies, uncommonly seen in younger women, but 36 to 40 years is the one where we are looking at a window of opportunity where the incidence could be 1 in 100. Now, why we are worried about, why we are talking so much about premature ovarian insufficiency, and that is because of its consequences. And when we think of consequences, the lack of estrogen would practically have its negative impact on all the organs. So there would be cardiovascular risk issues. So these women are more prone for impaired endothelial function. The lipid profile will go for a toss. Impact on bone health is something which is noted much earlier than in women who have natural menopause. So these women will suffer from osteopenia, osteoporosis, fracture risk, irritating problem of genitourinary symptoms. Of course, the sexuality issues will be there because of vaginal dryness, itching. It is also said that it does have an impact on the quality of life, psychological well-being, and in general, the life expectancy is reduced, and these women are likely to land up with premature death. So when we talk about cognitive function, typically it is noted that from bilateral oophorectomy would increase risk of dementia and Parkinson's disease. So we really have to consider this point, especially if we are contemplating removing the ovaries before the age of 50. As far as psychological well-being is concerned, POI has negative impact on the psychological well-being and quality of life. So easy access to psychologists and patient support groups plays an important role, and this is something as we as clinicians would keep in mind. When we talk about sexual functions, many a times women do not come up with the issues related to sexuality, but here they could be because of psychological stress associated with it. Of course, these women will be troubled by the vaginal dryness, itching, irritation, dyspareunia because of the thinning of the vagina. But infertility also can be a problem in some of these women. We must remember that even though we say that the ovarian function is on decline, there is still a small chance of spontaneous pregnancy for in about 4 to 10%. And pregnancy rates with autologous oocytes are not usually enhanced by fertility treatment, and many a time these women do require ovum donation. Coming to the etiology and why premature ovarian insufficiency is there. And when we talk about the etiology, most of the cases we are not able to pinpoint any specific cause. There could be some genetic issues which could be associated with it. Turner syndrome is probably by far the commonest. Trisomy X, that is 47XXX or a mosaic pattern, may be responsible for this syndrome. Some situations like infections, mumps, oophorytis, tuberculosis, etc., may be responsible for premature ovarian insufficiency. There are certain autoimmune conditions which may lead to this, but we must focus on certain condition. For example, bilateral oophorectomy. So whenever we are removing ovaries, think twice about the life of that woman after we remove the ovaries untimely. Remember women who undergo chemotherapy or radiation, and this leads to ovarian failure. Of course, some women who undergo pelvic vessel embolization for some other reason or environmental toxin may land up with premature ovarian insufficiency. And this is the general mechanism of premature ovarian insufficiency, where there is decrease in the primordial follicular pool, accelerated atresia of follicles, and there is defective maturation or recruitment of primordial follicles. And because of the sudden follicular death, this will lead to a lot of challenges related to the premature ovarian insufficiency. When we talk about autoimmune conditions, uh, autoimmune mechanisms may be responsible for about 4 to 30%. There are some potential factors like HLA, cytokines, etc. There could be certain conditions like Hashimoto's disease, which may be associated with premature ovarian insufficiency. Of course, we cannot forget the factors like smoking, more commonly seen in nulliparous patients. We also should focus on the family history of menstrual abnormalities, exposure to chemical. uh, all these things are really important, and we must not forget the recreational drug use, which is so common in the younger population coming to the clinical manifestation. First and foremost is abnormalities of the menstruation. So many a times women come to us with sudden onset amenorrhea. Of course, we must take into detailed history about the menstrual cycles earlier, which may be pointers for premature ovarian insufficiency. Of course, younger women with Turner's may be brought to us with primary amenorrhea. Some women around the perimenopause may come to us with the complaint of infertility, but the group that comes to most of us is with a lot of menopausal symptoms, which would include hot flashes, vaginal dryness, sleep disturbances. Hair loss is one of the common problems. Fatigue and anxiety and depression are the ones which really make life of a woman who's suffering from premature ovarian insufficiency a hell. When we talk about epidemiology, a lot of studies have talked about life expectancy, and so many studies have said that there is definite reduction in the life expectancy of a woman, and this is something which, as menopause practitioners, should not be acceptable to all of us. So we must try our best to offer whatever we can to improve the life expectancy as well as the lifestyle of that particular woman. So how do we approach this moment? Now, history taking and examination is extremely important. And when we take history in detail, there could be a family history of about in 30% women of premature ovarian insufficiency. So whenever we are taking menstrual history, apart from her menstrual history, we must ask about when her mother attained menopause, and some of them will tell us that their mother also suffered from premature ovarian insufficiency. Medical conditions should be looked into. Uh, Treatment with hormones earlier is something which has to be uh, documented. We also must look for endocrinopathies like diabetes mellitus or even hypothyroidism. Family history of premature ovarian insufficiency in first or even second degree relatives is important. These women may come with a history of recurrent pregnancy loss, symptoms of fatigue and weight fluctuation. And of course, whenever we are examining these women, they would certainly show signs of hypoestrogenism. So a pus speculum examination will probably reveal a thin vagina, which is really friable and which bleeds on. Clinical diagnosis would uh, be made when these symptoms are present. And if we want to diagnose a condition, mind well, whenever we talk about premature ovarian insufficiency, the first diagnosis is clinical. We may consider doing FSH levels, two levels of more than 25, at least 4 weeks apart, would be diagnostic. But if we want to rule out other conditions, say for example, if we have a woman who comes to us with amenorrhea and rather than POI, she may be pregnant, so a beta HCG level would be diagnostic. Uh, we should also look for other conditions. So TSH levels, TPO antibodies may be advised to certain women. Women who show signs of POI and are keen on fertility may be offered AMH levels. A transvaginal ultrasound would reveal the antral follicular count, which is on the low, indicating that the ovarian reserve is poor. But very important investigation for all of us is to do a DEXA scan to assess bone density in these. We may have a woman who will show biochemical evidence of hypergonadotrophic hypogonadism. AMH may be very, very low. Transvaginal ultrasound will tell us a little more about the ovaries, and of course, the endometrial echo would be thin. However, radiological imaging is not essential to establish the diagnosis. We've already talked about AMH, so I'm not going in detail. Coming to the management, I would restrict myself on about uh, the therapies for premature ovarian insufficiency as far as from the menopause aspect. I'm not going to talk much about fertility. It is really important that these women are counseled well. They would require a good lifestyle measures to reduce the risk of comorbidities associated with POI. So a good diet exercise pattern is a must. 45 minutes of weight bearing exercise, as we recommend to all perimenopausal women, should be continued, and we must give emphasis on its importance to protect their bones. And um, the therapy would include the menopausal hormone therapy, and it has to be tailor-made to our women. So the goal of hormone therapy in premature ovarian insufficiency is to mimic endogenous level of sex hormones, which equates to a serum E2 level of about 100 picograms per ml. And once initiated, the hormone therapy should be continued till the natural age of menopause, 51 as in Western countries and at least 46 as in our. So IMS recommends these three therapies for premature ovarian insufficiency: a standard or high dose estrogen in a cyclical or continuous fashion. Progesterone has to be added in case the uterus is present. Oral contraceptive pills, if they are not contraindicated, may be offered to younger women, and tibolone also has its own place in management of premature ovarian insufficiency. When we talk about estrogens, we do have a good variety, a 17 beta estradiol in the dose of 2 to 4 milligrams per day, or conjugated equine estrogen, which all of us have been using for years. We now have a transdermal estrogen, which may be offered to these women, and one can consider offering 30 to 20 micrograms of ethinyl estradiol. When we talk about progesterone, we know that micronized progesterone or dydrogesterone are probably the best. And if there is no contraindication, one can think of giving a combined oral contraceptive pills, uh, which women can continue using for a long duration of time. And when we talk about testosterone, women who have low libido, uh, where especially after oophorectomy, we can consider giving testosterone, though it is not really available. There are so many studies which talk about use of testosterone in protecting the cardiometabolic health of a woman. And of course, it is important for the health of the bone as well as the muscles. Uh, this is a head-to-head study which talks about COCs and MHT, and what uh, it concluded was these two therapies are really important in order to protect the bone. And of course, the BMD was seen in a better or improvement in BMD of lumbar spine was seen better in women who received MHT. So when we talk about premature deprivation of estrogen, this is typically secondary to bilateral oophorectomy. These women are likely to develop neurocognitive decline. So we have to counsel these women about the change in the cognition, especially secondary to premature ovarian insufficiency. So whenever we are talking about psychological status, these women would lead to a difficult life because there would be reduced self-esteem, social issues, anxiety issues. Women may experience shyness, and these women will be depressed. So they need to be counseled. If need arises, we should take help of our psychiatrist colleagues in order to improve the quality of life of this woman. So whenever we decide to prescribe the menopausal hormone therapy, this is the chart which is given by IMS is the gold standard. It talks about how to select a patient in whom not to give hormones and what cautions to be exercised in certain group of women. So once we decide to give hormone therapy, a good counseling is a must, and these women should be explained as to how they are supposed to take uh, the medications at the right time. We need to also give emphasis on importance of follow-up, and we must tell these women that though we are providing hormones in the form of menopausal hormone therapy, they do not offer any kind of contraceptive protection. So they need to take due precautions as far as fertility is concerned. Some special groups, younger women or young girls who are brought to us with Turner syndromes, they need to continue taking COCs throughout their lifetime. What about women who come to us with premature ovarian insufficiency with a BRCA gene mutation? Now, we know that for breast cancer survivors, hormone therapy is contraindicated, but hormone therapy is a treatment option for women who are carrying BRCA mutations, but without a personal history of breast cancer, especially after uh, women who have undergone prophylactic bilateral salpingo oophorectomy. Women with endometriosis, and here we need to remember that we always have to supplement progestogen therapy for these women along with estrogen, especially we are when we are treating their symptoms. Here we have to keep in mind the risk of disease reactivation. So only estrogen therapy would not make sense. What about women with migraine? We know that we cannot offer hormone therapy to them. So lifestyle modification is something which has to be emphasized about. What about women with fibroids? Now, these women can receive menopausal hormone therapy. Women who are obese, transdermal route is preferable. Women with hypertension, again, it is not a contraindication for MHT use, though we would prefer a transdermal route. And women with thromboembolism, we of course have to take into consideration suggestions by the hematologist, and transdermal is the preferred route for these women. So role of hormone therapy estrogens, COCs, and even gonadotrophins can be offered in some women. And here the literature talks about the symptoms which definitely need attention, and that is vasomotor symptoms, genitourinary symptoms, bone health, cardiovascular health, and sexual function. Of course, the therapy that we offer, especially the menopausal hormone therapy, may or may not have an impact on life expectancy or even quality of life. But we should offer these therapies to women if the benefits outweigh the risks. And these are the two preparations which are available, which are safe, effective, and can be considered till the natural age of menopause. Coming to the fertility preservation, and here we have to reiterate the role of in vitro fertilization, and many times we may have to use the donor oocytes because these women do not produce good quality eggs. So to conclude, premature ovarian insufficiency remains an enigma. Most of the cases we are not able to pinpoint any cause. It is a state of estrogen deprivation which holds both short-term and long-term implications for health and even for psychological well-being. Timely initiation of hormone therapy and a multidisciplinary approach is a must. And I would uh, conclude by these recommendations by Indian Menopause Society, which say appropriate counseling, lifestyle modification, and hormone therapy form the basis of the treatment. Hormone therapy should be started as early as possible in women with POI and continued till the age of natural menopause, that is 46 to 47 in our country. Emerging evidence suggests that physiological doses of hormone therapy is superior to hormonal contraceptives, and androgen therapy must be considered women who have persistent fatigue, loss of libido in spite of estrogen therapy. We must counsel women that hormone therapy is not contraceptive, and erratic ovulation and pregnancy may occur in women with POI who are on hormone therapy. And there is no evidence that hormone therapy increases the risk of breast cancer, CVD, or dementia over and above that found in menstruating women with a normally timed menopause. So thank you very much.